Well, it looks like we've got some folks, so let's get to it. I am joined today by Dr. Lucy McBride. Dr. McBride, thank you for being on Urgent Futures.
Thanks for having me.
I am so grateful that we have a chance to talk about this because it's something that I've run into in my personal life and I've been running into in conversations with, folks in my life. And so today, the focus, you have so much to sort of bring to a conversation, but today the focus is the CDC chaos and COVID-19 vaccines. So to that end, I want to set a brief timeline. I have it right here, so I'll be kind of looking slightly off screen for folks just to give a sense of what's happened, and then I want to dive in with you. So
Great.
August 27th, the FDA revokes the last emergency use authorizations for the COVID-19 vaccines, meaning that vaccines would only continue through traditional approvals or limited mechanisms, which narrowed availability. In late August, Susan Menares is abruptly removed just weeks after the Senate confirmation. Multiple senior CDC staff resigned soon after, raising concerns about the stability of vaccine policy and communication. On September 4th, the FDA approves updated COVID vaccines for only adults 65 and older and people with high-risk conditions, but the high-risk definition remains vague. On September 7th, the World Health Organization publicly urges that the CDC's scientific independence be protected, citing concerns about political interference during U.S. vaccine policy shifts. And on September 18th to 19th will be the CDC Advisory Committee on Immunization Practices meeting, where they're scheduled to meet and review and update COVID vaccine guidance. Is there anything in that timeline that also deserves mention before we dive into it?
No, that's a good sort of layout of the timeline, and it is the reason why people are distressed and anxious about and confused about what to do.
Yeah, so let's start there. Given your own, independent professional practice, but also, through your Substack, Are You Okay? Everybody should go subscribe to that right now if you're not already. What are you seeing? What are you hearing from folks?
So, just to frame this conversation, I'm a primary care doctor. I'm in Washington, D.C. I see patients every day. I also write a newsletter weekly with a Q&A section also once a week to help people make sense of all the noise out there in the medical space. We are inundated with panic and fear-inducing headlines with one study says this one day, another study says this another day. People are confused and perplexed about what to do, not just about COVID vaccines, but about how to protect themselves and their families in an era of misinformation, disinformation, and an era of chronic illness. We also live in an era where 100 million Americans don't have access to primary care doctor, which is ideally the very place you would have the conversation about something like the COVID vaccine. Doc, what do you think? Here's my underlying health. Here's my risk. What do you think? Right. So the nuanced conversations that are supposed to be happening in one-on-one settings with your primary care doctor aren't happening because people don't have a primary care doctor. And then, of course, the CDC is a institution that is supposed to give us broad guidelines, right? It can't possibly speak to every individual, right? That's for one-on-one conversations with your primary care doctor. But the CDC is there to provide expert guidelines, a frame within which we can operate as physicians and talk to our patients. So what I'm seeing on an everyday basis is chaos and confusion. This is partly why I write my newsletter, is to cut through the noise and to make sense of complex decision-making. And people don't know what to do, and they don't. And then on a very practical level, they are hearing from CVS that they need a prescription for the COVID shot, even if they meet criteria. They're 65 or they have an underlying condition. And then they're told by Walgreens they don't need a prescription. So we're in a very volatile and stressful, moment of time, and especially before the ACIP meets on the 19th. The ACIP is the expert committee that is supposed to advise the CDC on recommendations. The ACIP was a 17-member committee that was gutted under RFK. The whole committee was told to take a hike. So, and then it was replaced by people who may or may not be the best people to advise the CDC. It's not really for me to say. It's just to say that there's, you know, the accusation by RFK was that the ACIP, this Vaccine Advisory Committee, had people on it who were owned by the pharmaceutical company or who had been ideologically captured in some way, such that they were not going to be unbiased guides to the CDC. Well, it's not clear that the new committee isn't biased in some other way. Not to mention, we don't have a CDC director right now to sign off, or if we do, I'm not sure who that person is. I couldn't name that person right now. So that's the landscape we're in.
Boom. Well, I guess we'll find out this coming week if there is somebody to make that call. I want to ask a bit of a sort of vague, and I don't mean it as a leading question, but I want to sort of get your perspective on what you see as the root cause for the turmoil at the CDC.
Oh, politics. Science plus politics equals politics. So even under the Biden administration, by definition, the CDC is a political entity, right? It's a political appointee at the HHS. It's a political appointee, the CDC director. But before this administration, I, as a physician, and my colleagues in medicine didn't doubt the adherence to the best available science, to integrity. And that has come into question with this administration. I'm not here to tell people how to vote or right or left. I think there are many things that RFK as HHS is right on the money about, believe it or not. Like, I think that our food supply is not ideal. I think chronic disease is something we absolutely need to target. I think that to the extent they are trying to regain trust that was in part lost because of policies that were made during the pandemic, it's not successful. The Make America Healthy Again movement plus RFK's gutting of the CDC has done the opposite. It's not inspiring trust, at least in my patient population. It's only creating more confusion.
Got it. And let's push in a little bit more on that, because I'd love to hear your perspective on. We've talked a little bit about both of these things, but I want to kind of push deeper on both of them. So, what do you see the MAHA movement as doing that's maybe beneficial long term when we think about healthcare? And what do you think is coming out of the MAHA movement that is maybe harming ultimate, good public health outcomes?
So I think that we can agree that the healthcare system is not serving Americans, regardless of politics. I think we can agree that the healthcare system in this country is broken. The healthcare system is frankly anti-patient, anti-doctor. It is pro-pharma, pro-insurance company. So I think that we need a different system. We need a new system. We need a system that serves patients and that allows doctors to have time with their patients. Right now, the system is set up such that we privilege volume and insurance reimbursement over time with the patient and outcomes. So if you're in academia, if you're in an insurance-based medical practice, you're seeing a patient every 5 minutes. You are much more likely to write a prescription and write a referral and sort of try to get that person out the door than you are to sit down and talk with them about the nuances of their type 2 diabetes or their blood pressure. Not because you aren't a good doctor, but because the system doesn't allow you that time. So I think that what was potentially good about a disruption in the healthcare system was that we need innovation. We need a new way to address chronic illness. We need to reckon with the fact that as a rich country, we have the really terrible health outcomes. Despite the technologies that we have, and we can, map the human genome, like people are sicker and sicker, and the access to care is getting more difficult. So, putting on my apolitical hat, I was hopeful that perhaps RFK, as much as I disagree with a lot of what he says, I disagree with a lot of what he says. I think he sows distrust in vaccines. I think there's harmful rhetoric, absolutely. But I also am ever hopeful that we could invent the healthcare system such that we are addressing the root causes of illness and not just band-aiding them with prescriptions. Most patients in this country, if by the time they're 80, they have a doctor for every body part if they have health insurance. They have a prescription for every complaint, and doctors are not talking to each other. And they get shuttled to ERs and, urgent cares and don't know who to trust. 5% of healthcare spending in this country is spent on primary care. The rest is on damage control, hospitalizations, ER visits. So I'm ever hopeful that we will somehow get it right in this country where people have access, unfettered access to a primary care medical home to understand the whole person. Okay, so that's what was my hope with the MAHA movement. Yes, the food industry needs some, CPR. And yes, we need people to understand root causes. But there's no clear plan from coming out of MAHA for what they're going to do. They just are sort of tearing things apart. Like where we needed some precision, surgery on the healthcare system, we've gotten a sledgehammer. So let's back up to the pandemic. So the pandemic, I did a lot of public facing work during the pandemic, speaking about balancing the risks of the virus in a public health messaging against the risks of the mitigation. So I think there's an argument to be made that the pandemic related policies cause some distrust in public health. And that's not political. That's actually borne out in the data. We see that trust waned significantly during the course of the pandemic because I think after we got a vaccine that was amazing and life-saving in certain populations, a lot of the restrictions were held on to and people lost trust when they saw that the vaccine no longer protected against infection. It protected high-risk people from landing in the hospital. That's what it did. So I think people were ready for, regaining trust in their CDC and the healthcare system. And I think RFK and the HHS has not done that so far. And I mean, maybe he's got some fans, but I don't think they're doing anything to regain people's trust.
Mm. So you were setting up very naturally for me to ask about medical maximalism, which I really want to talk to you about. But what you just said right at the end there, I want to sort of detour there first, is what could they be doing now, RFK and the CDC broadly, to restore public trust, both in terms of the trust that was lost prior to RFK and also the trust that's been lost since RFK's assumed the role?
Well, so if you're like me and you're like my patients, you trust messengers who adhere to facts, who acknowledge uncertainty and acknowledge what we don't know, who change or adjust their recommendations based on changing conditions, and who acknowledge that science is iterative, that we're never certain about anything, right? Like that's just the nature of science, is that we're never done. It's never like science is wrapped in a bow. And you trust messengers who acknowledge that risk is on a continuum, that the American public does not represent a monolithic body of people, right? We have different risks based on our age, our demographics, our underlying health conditions. And then I trust messengers who are humble and say, I don't know. So I think what happened during the pandemic is that in an attempt to, deal with the atrocities, the losses of lives and loss of, economic stability and kids being out of school, the CDC hit people hard with this messaging about the COVID vaccine, as they should have, but with much more nuance. It would have gone a long way, for example, if Rochelle Walensky or the CDC messengers or Fauci had said something like this: okay, it's 2021. The Delta variant has arrived. We have a vaccine. It is accessible to all. We've given everyone time to, take a day off work or have access to the vaccine. The vaccine, however, in 2021 is no longer blocking infection. It just isn't doing that. That's not to say that the vaccine isn't a modern miracle. That's not to say that the vaccine isn't wonderful at doing the job we need it to do the most, but it just doesn't block infection. It doesn't block you from getting COVID. It doesn't really reduce transmission to other people in a meaningful way. So, what it can do is what we should celebrate, which is that it can help people at highest risk for severe disease not get seriously ill and need hospitalization. So let's talk about how to manage your risk and how to understand, whether you can go back to school, whether you can go back to work, how to manage getting COVID when you get it, because inevitably everybody will. And let's then pull back some of the restrictions so people can make individualized decisions and arm them with tools to do that. But instead, masks and vaccine mandates were still going. And it just doesn't make sense to mandate a vaccine when it doesn't protect other people. We should, in my opinion, this is opinion, we should mandate the MMR vaccine because the MMR vaccine is different from the COVID vaccine. The MMR, the measles vaccine, protects me and it protects you. When I get the measles vaccine, it protects me from getting measles. It also protects other people. So that should be, in my opinion, that should be mandated because it's a public health intervention. We don't mandate the flu shot. For the same reason, I don't think we should mandate the COVID shot because after 2021, the Delta variant arrived on the scene. It outskirted the vaccine's ability to protect from infection. After that moment, it was an individual choice, but it wasn't messaged that way. Fast forward to now, what could RFK and the CDC do to re-earn people's trust is to say the same thing. Hey, it is true that the vaccine is most effective for people over 65, the people the FDA has approved it for. It is true. Those are the people who stand to benefit the most from the COVID vaccine. If you're at risk of going to the hospital because you get a cold from RSV or a virus or any other virus, COVID, flu, or a flu-like illness is high, you stand to benefit the most from the COVID vaccine. But those of you who are low risk can certainly get it. I would have a more permissive policy if I were the head of HHS right now. I would say, look, these are the people who absolutely we think should get it. These are the people who I think are allowed to get it. We're not going to restrict you from access to the vaccine, but know that the risk is individualized and it may not do much for you if you've had COVID 3 times and you're a 20-year-old. It may not do much for you. But instead, what the FDA and the CDC seem poised to do is to restrict vaccine access to only the highest risk people. And that to me is just going in the opposite direction and wielding power to, in my opinion, sow distrust in vaccines at large. And it's a little bit of like a I told you so. It feels like I told you so to the previous administration. It's just political football. The vaccine and the virus do not vote Democrat or Republican. It's just a virus. We know how to protect people from it. Let's message that to everybody and message the fact that your risk is different from your neighbor's risk. Your risk is different from your grandmother's risk and from your son's risk. And that is just fact.
So just to recap what you're saying, and please tell me if I got this wrong, your general sense is for viruses that vaccine produces public health level sterilization, that those should be mandated. But the ones that are more built around individual protection should be the individual's choice.
Yeah, I think people should be given the information about what these vaccines do and don't do. But if you get the MMR vaccine, so yes, I think that is what we've agreed on as a society. That's why kids are mandated to get the MMR shot. And I think in order to mandate a vaccine, you also have to have really rigorous evidence to show that the risks are teeny, right? The fact of the matter is that nothing is risk-free, right? Like nothing is risk-free. No intervention is risk-free. but to weaponize the tiny bit of risk that the MMR vaccine might have to sow doubt in vaccines at large, to me, is irresponsible. At the same time, let's acknowledge that we don't know everything. We can't guarantee that there's zero risk for anything, including a vaccine. Someone's asking a really good question. I don't know if you want to answer it, but
No, please.
the COVID vaccine was for public health safety. It was. So just to be clear, this is where we really got. Someone's asking, wasn't the issue that we thought that the COVID vaccine was for public health safety? It was. So you guys probably remember, everyone who's listening, at the end of 2020 and in early 2021, I was messaging to my readers and to my patients that, oh my gosh, this is amazing. This vaccine is not only protecting you from going to the hospital, it's actually protecting you from getting infected at all. And when it protects you from getting infected at all, it's going to protect you from spreading the disease to somebody else. So it was thought to be this miracle, or this kind of vaccine that was sterilizing. But then you got the Delta variant in 2021 spring, and it showed that you can have 2 shots, 3 shots, 4 shots. You can have had COVID before, and you can still get COVID. So conditions changed. The virus changed. The messaging did not. And people saw with their own eyes. I mean, you probably saw, my kids got COVID. They had all the shots, and they are mandated to get boosters, and they still got COVID. And that's not the vaccine's fault. That's just the behavior of a virus. So we should not mandate, in my opinion, a vaccine that isn't providing benefit to other people. It's just for the individual. That should be an individual choice, in my opinion. Now, not everybody agrees with that.
Yeah. And so first of all, Lizzie, thank you for that question. And as a follow-up for folks who are viewing, listening, et cetera, please feel free to leave comments in the chat. That's why we're doing this as a live. So yeah, Lizzie, thank you for that. I want to touch on the kind of external factors that are sort of in the thought cloud of vaccine, which is you've got folks on the one hand who are concerned about the impacts of long COVID, both at the individual level, but also at the public health level, and the ways that vaccines do and do not tie into that. And you have folks that are concerned about mRNA being a novel technology and us not having clear data or research about what the long-term effects of that are. So player's choice. I don't know where you want to start with those.
So regarding long COVID, so I have a couple patients with long COVID. The patients with long COVID are patients who have a long tail of symptoms after the virus. So a couple things about that. One is that it has always been true that viruses in some subset of people can cause a long tail of symptoms. There's chronic fatigue syndrome that is thought to be because of Epstein-Barr virus or the monovirus. So it's not new in medicine for doctors to see patients who, a subset, have a long tail of symptoms. So it's not clear that it's unique to COVID, but let's say it is. Let's say we decide it is unique to COVID, that long COVID is a distinct entity separate from the long tail of influenza or the long tail of monovirus for other people. The best evidence we have so far is that the vaccine helps protect against long COVID. It makes sense, right? The vaccine, if it's tamping down the amount of virus that's circulating in your body and it's protecting you from severe disease, particularly if you're high risk, then it would help protect against long COVID. It makes intuitive sense, and that's what the data we have so far suggests, which is in part why I think if we're going to have a more nuanced policy around access to the COVID vaccine, why I think it should be permissive. It shouldn't be restricted only to people who are deemed high risk. It should be available to anybody who wants it, because long COVID, while increasingly rare in the era of vaccines and people have had COVID and they've built up a level of immunity, it still is a possibility.
Got it.
And the second part of your question was about
mRNA.
So mRNA, billions of vaccine doses have been given, mRNA vaccine doses, and it's thought to be extremely, extremely safe. However, like I said about any medical intervention, there are potential risks. The only the only important signal that I've seen is the very rare but real risk of mRNA vaccine induced myocarditis, which is the inflammation of the heart muscle in adolescent and young adult boys, males. Still, very rare, but real. And that, in my opinion, should have been messaged during the pandemic. That would have earned people's trust, I think, to acknowledge that, because that did happen. Now, it's important to recognize that COVID itself, the virus itself, can cause myocarditis. I see heart inflammation. So heart inflammation because of the virus. So we're talking about, a tiny risk over here of the MRA and a tiny risk of, serious outcomes from COVID in a young adult male. So it's why it's not a no-brainer to give, for example, my sons who are in their early 20s, their sixth vaccine dose. It's not going to do much for them. However, they're adults. If they want to take it, that's completely fine. I wouldn't blame them. So I think, and by the way, if you're hesitant about the mRNA technology, which I personally am not, you can get the Novavax shot. The Novavax shot is a more traditional vaccine delivery system and platform.
And it
But
does
in
seem
general,
people
the
are
mRNA, the sort of fear mongering about mRNA to me is out of proportion to what we know about mRNA.
got it. So a couple questions came in the chat, both of which I think are going to be applicable more broadly. The first one is from Brenton, who was asking around the MMR vaccine. If you got an MMR vaccine as a kid, do you need to get a booster for it now?
It depends on when you were born, but 2 vaccine doses of MMR is 97% effective at preventing measles and then transmitting it to other people. So if you didn't get 2 shots, or if you were born in like the late 1950s, early 1960s, where the vaccine wasn't as effective, what I would suggest is go to your doctor if you're lucky enough to have one and check an antibody level to see if you're immune. It's supposed to be lifelong immunity if you get the 2 shots. Or just get a booster. And so you've had 2, and then you don't even need to check titers.
Got it. Thank you. And then Bonnie's asking or saying, I got last year's COVID shot because it was all that was available, and I'm doing a lot of travel and wanted some protection. Will it provide any?
So that's a great question. The answer is that in 2025, the COVID vaccine does not block infection. It can't prevent infection, right? Its superpower is its ability to prevent people at highest risk from ending up getting severely ill. It's not, though, 0% effective at preventing infection. It's not a nothing. It's not a nothing. What a booster will do, or another vaccine dose will do for you now, for anybody, is give you a transient increase in your antibody levels. The antibody levels start to rise immediately when you've had the shot. They peak 2 weeks after you've had the COVID vaccine. And that extra little juicing of your immune system, that extra amount of circulating antibody reacting to the vaccine, does provide some modest protection against infection, but it's not that great. And so what I worry about is people thinking that they got the shot and then they're covered, right? That they're immune. If you have had the shot and it's been 2 weeks and you're at an indoor wedding and your intent was to get the shot to protect you from not getting COVID during the wedding, and you're sitting in a small room or something and someone's coughing all over you, there's no amount of vaccine dose that's going to protect you from getting COVID. This is not anti-vax. This is just the facts of the matter. This is just the limitations of the vaccine, which is not the vaccine's fault. It's the fact that the best way to prevent getting COVID in this era is, sure, get vaccinated with all those caveats and stay home when you're sick and, protect yourself by keeping your underlying health conditions in check.
Perfect. Thank you. Okay, now, at long last, medical maximalism, and specifically with a lens on where medical maximalism intersects with this conversation around COVID and the COVID vaccines.
So defining medical maximalism, what I call medical maximalism is when the medical system, as it is, an imperfect, flawed system, tends to treat patients as a set of body parts and a collection of symptoms instead of the person. There's sort of no more perfect example of medical maximalism, in my opinion, than when we're addressing patients towards the end of their life. I don't want to direct this conversation into end of life care and that kind of thing. We're talking about COVID. But for just a second, one of the problems when we're addressing patients at the end of their life, my older patients, my patients with cancer, is that the medical system tends to treat the cancer and not the patient. The default pathway is to have people on chemotherapy, to have most aggressive measures up until the day they die, instead of centering the patient's wishes and desires and centering them as a person. So how does it apply to COVID? Is that I think people, depending on who you are, you might say that the pharmaceutical industry, Pfizer and Moderna, um, are owned by, the federal government, or, there's so much bias, implicit bias, that the recommendations in the previous administration for everyone to get the vaccine, for everyone to get boosted, was medical maximalism at worst. Was medical maximalism at best, and then at worst, it was just flagrant bias and treating people with vaccines who really just needed to lose weight and exercise and manage their underlying health conditions. I'm not sure that answers your question. Do you have a more specific question about the concept?
Well, I was glad to hear you define it, and I think what I appreciate so much about the concept is that it's extremely nuanced, and I think COVID is just one of these zones where nuance goes to die.
That's right.
And so I was just wanting to get your perspective. What I sort of wanted to lead into is we're getting a lot of mixed messaging from the CDC about not only who should get the COVID vaccine, but who can. And
Right.
so thinking about folks who might be in a more, conducive state to getting the vaccine, meaning geographical state, not state of being, or who are able to, get one at a participating pharmacy, but then they're still not sure because of some of the doubts and concerns we've heard before. If you're a parent worried about vaccinating your kid and not sure, which way to go on that, if they have a health condition, if they don't. So I was just, wanting to open up a broader conversation in
Well,
that.
I think the medical maximalism concept to me is really about the absence of nuance in our medical system and how we default in medicine to prescriptions, referrals, accidentally disempowering the patient by not giving them the nuanced information they need to make complex decisions, whether it's about getting a COVID shot or deciding on another round of chemotherapy for my cancer versus I'm going to actually decide to be in hospice at home and be surrounded by loved ones instead of dying in the ER with, tubes and beeping noises around me. So I guess it speaks to the inherent challenges we have in our medical system where it's much easier to take a pill and to, you know, get a vaccine sometimes than it is to understand your own personal risk. And that's not because of the consumer's fault. It's not because of the farm. It's not doctors' fault either. In fact, doctors and patients, I think the general public are kind of victims of this system, regardless of your politics. Like the system is broken. So the default is for doctors to prescribe medications and give patients very little time to be empowered themselves to understand, okay, maybe I don't need Lipitor for my cholesterol. Maybe I just need to limit red meat and add more fiber, which is known to help reduce cholesterol. However, if you're someone with coronary artery disease, proven cholesterol plaque in your arteries, there's no amount of dieting and exercising that's going to protect you from heart attack without a Lipitor prescription. So that is just the definition of what I do in my job. That's what primary care doctors do all day. It's just that when you don't have access to a primary care doctor who has time to discuss these things, the system will grab you. And high cholesterol means Lipitor. You're depressed, Prozac. You have foot pain, you're on a pain medication. Well, not everybody who has depression needs Prozac. I love Prozac. I think it's a wonderful drug. I prescribe it all the time. But what if your depression is born out of a childhood trauma, or it stems or is exacerbated by a toxic relationship at home or at work? There's no amount of Prozac that's going to help you extract yourself from an abusive relationship. There's no amount of Lipitor that's going to help you, take out the coronary plaque in your arteries. Um, so we need to understand patients need to be empowered with the nuances of their own bodies, right? We are living in an era where people are pretty darn disconnected from the medical system and also pretty disenfranchised from their own bodies. And they're given prescriptions and they're given recommendations that are blanket recommendations, and they don't trust sometimes their own doctors.
Mm.
So, I think this is actually, I'm writing a book about this with Simon Schuster. It's coming out in 2026. It's called The Empowered Patient, a doctor's guide to reclaiming your health. And it's not about optimizing or longevity. It's not any of those buzzwords in the wellness industry. It's not about like, do as I say. It's about, here's a way to think about complex problems. Here's a frame within which you might contemplate hard decisions about your health, whether it's cancer or high cholesterol. And here are some things you might bring to your own doctor to ask. Here are some questions you could bring to better extract the information you need for yourself.
Mm. Well, I'm very excited to read that book. I'll have to have you back
Me
on. We
too.
can do a dedicated conversation about that book.
Yeah.
Well, and I remember, and when I was reading a piece you wrote a week or so ago, you brought up a stat that I was unfamiliar with, which is that we're short, is it 42,000 primary care doctors, and projected to be, I believe it was 68,000 by 2030 something.
Yep.
So yeah, like in that well, I guess I sort of have two quick questions, or they're not quick at all, but I'll ask you to answer them quickly in the interest of time. I'm wanting to know the root causes and sort of, the sort of systems that caused us to get into this state of medical maximalism on the one hand. And at the very, very individual level, in addition to, having these conversations with your doctor, what do you do to try to bring more of this, cohesive systems approach to your health rather than the, doctor per body part, Band-Aid style pill for every ailment, et cetera?
So how did we get here? It started a long time ago, but it's instead of providing value-based care, it's basically volume-based care, because the insurance companies reimburse physicians and big hospital systems for volume. It's as simple as that. So you're incentivized to see people fast, churn them out. Again, not doctor's fault, not patient's fault. It's the insurance-based system. It's not really insurance-based system isn't really a healthcare system. What we should do is provide value and improve quality of life in addition to quantity. So that's the short answer to that question. The other question to how are we going to solve this mess? I actually am optimistic, believe it or not, and not just because I'm an optimist. Um, I think that this era of disruption, while it is horrendous, and I think we've overshot the mark in the healthcare and in HHS. I mean, I think the disruption is now just like destruction. Um, I think there's an opportunity to really rethink what the healthcare system looks like. I think there are a lot of smart people out there thinking about how to use technology in a smart way, how to leverage even AI. And I'm going to caveat this in a second, but how to leverage AI to help doctors work more efficiently, to have time with the patient, to use AI to enhance, not eliminate the relationship. Silicon Valley could do this really badly, and then that might happen. That the tech just makes crappy systems in healthcare more crappy, and we just see more patients, and we're incentivized to just see patients even faster than we already do, and not to center the human being, not to center the patient-doctor relationship and the conversations that happen in the office. But AI, if done well, with primary care doctors using and leveraging AI to help enhance, not eliminate the patient-doctor relationship, and we make primary care not the stepchild of the healthcare system, but rather the main dish where everyone has access to primary care, we could really, really, really do a lot of good for human beings. We would also save a ton of money. Um, as I said in the beginning, only 5% of healthcare spending in this country goes to primary care. 95% goes to ERs and hospitals. Now, you can't eliminate emergency room visits. You can't eliminate hospitalizations. Like, those are going to happen. I'm just saying that the incentives and the spending is, ass backwards. We should be working on prevention. We should be helping people be armed with data and information to manage their health and not waiting to have the heart attack and go to the hospital and die surrounded by doctors and beeping machines. We should have patients understand their options and the facts of their health situation.
I love that. And it echoes a lot of the work that I do is focused on the kind of public dimensions of like where my work intersects with this work is looking at polycrisis and climate crisis. And you can make the same prescription toward looking at climate crisis is like building resilience saves money in the long term, then constantly focusing on remediating the damage after the fact.
That's right. That's right. And by the way, medical maximalism, just to put a little asterisk on that, there's so many people in this country who don't have access to a doctor at all. There's no medical maximalism at all. It's just no care.
Yeah.
Right. When I was training at Johns Hopkins, and I worked in the ER I helped staff the ER after I finished my internal medicine residency because I needed shift work to decompress from my residency training. We weren't just treating heart attacks and strokes. We were providing primary care for East Baltimore. I mean, people don't have access to primary care doctors, so we were providing in the ER, insulin refills for people who didn't have access to a primary care doctor to get their insulin. We were providing, antibiotics for basic UTIs that, you should see a primary care doctor for. We were providing mental health services for people who couldn't get into a mental health provider for months or years and who didn't even have insurance to have that stuff covered. So medical maximalism really depends on, it depends on who you are as to how you're being treated in this country. I mean, the inequities are terrible. And I think until we reinvent the healthcare system and center primary care as the medical home for everyone and center the patient and the human, not just the diseases and the body parts and the illnesses, we're not going to make any progress. So this whole COVID vaccine restriction by the FDA and the CDC, to me, is a distraction and just kind of a complete distraction from the actual problems Americans are facing. They want someone to trust. They want someone to listen. They want to understand the facts and the nuance. Not everyone who's declining a COVID vaccine is an anti-vaxxer. They just see with their plain eyes that what the COVID shot can and cannot do. So I think we need to stop, blaming and shaming each other and actually just have people to trust in the medical space, not just wellness influencers, not just people on TikTok, but actual physicians and people who acknowledge what we don't know and acknowledge uncertainty.
Well, that's why I feel very lucky to be speaking to you today. I want to close the conversation with the very, very brass tacks, your take on kind of recapping some of what you said in that recent post about your overall guidance around folks who are thinking especially thinking about the folks who might be medically disenfranchised, don't have a primary care, or they're, a long way off from having their introductory primary care appointment. They're like, what do I do? Should I get this vaccine? Should I not get this vaccine? What's your kind of overall recommendation without, I know that there's liability and things.
No. There's nuance to it, but if we know that age is the biggest risk factor for developing serious consequences. We also know that most people in this country have had a couple vaccines and or COVID itself, which does provide protection against the next time you're encountering the virus. So if you've had COVID before, if you had vaccines before, there is lasting T-cell immunity, cellular immunity, that is at the ready to help protect you the next time you're exposed to COVID, which is different from the flu vaccine. The flu vaccine doesn't generate the same kind of cellular immunity, T-cell immunity that the COVID vaccine the COVID and the COVID vaccine too. So the short story is, those of you who are at highest risk for severe outcomes, needing to go to the hospital or the ER or needing supplemental oxygen, are generally the people who are older, so 65 and up. So I would definitely get a shot if you're 65 and up. That said, remember, I have 70-year-old patients who are running marathons, and I have 65-year-olds who, and I have 50-year-olds. I have unfortunately a number of patients who have serious terminal illnesses in their 50s and 60s. So it depends on who you are. 65 and up, I would get it. And if you have an underlying health condition like diabetes, like obesity, like kidney, liver, heart disease, if you're immunocompromised, you are someone who is probably at higher risk for severe COVID outcomes. You probably have already had COVID and you've seen what it does to you. And some of you may have had a mild course. Some of you may have gotten really sick. It's not just about the vaccine. It's about how much virus you inhale. Like how sick you get depends on how much virus you inhale. It depends on your underlying health conditions. It depends on how recently you got a boost from another vaccine dose or had COVID itself. So if you're wondering, I would say just go get it. The downsides are minimal, we think, unless you're in that category of young adult males, in which case I'd say you might still want to get it just to be extra cautious, get the extra little boost of antibodies. But, there are potential downsides that are also minimal.
Mm. And to recap something you said earlier, also remember what it's actually doing. It's not
it's not a force field. It's not a force field. I think of it as like the COVID vaccine in 2025 is like it's like wearing a raincoat out in a storm, right? You've got some protection, but you're still going to get wet. If it's storming really hard, which is like you're inhaling a lot of virus because you're sitting in a car with somebody and they're sick. If it's storming really hard, the raincoat, you're still going to get wet. Your socks are going to get wet. Your feet are going to get wet. But it provides something. And particularly if you are at high risk, like you have a raincoat with holes in it, or you forgot your raincoat. That's the analogy to like someone who's elderly or infirmed. Then like you need to get that vaccine dose. You need a booster to get a stronger raincoat. Is that I don't know if that
That's a
translates.
beautiful answer.
Okay.
Yeah. Raincoats are great. We've covered a ton in this conversation. And again, I'm so appreciative that you took the time. Are there any questions that your patients or folks in your life are asking you on these subjects that we didn't get into that's worth sharing?
Yeah, people are asking, do I need a prescription for the vaccine? And the answer is, it depends on the pharmacy. So some pharmacies are giving it out, and some pharmacies are like, they need an actual prescription, which is super unfortunate because it just becomes an access problem if you don't have a doctor to write a prescription. Other people are asking me, is the new formula out? Is the new formulation of the COVID vaccine out? And the answer is, I think it is. I actually don't completely know. But the new formulation is supposed to be out like nowish. It would have been out if the ACIP committee hadn't been gutted. And I think the reason why we're in this little strange space where people don't know if they need a prescription or don't know if the new formulation is out is because the ACIP has not met yet. That committee has not yet met to then have the CDC sign off on the recommendations. And I think pharmacies are worried that they're not going to get reimbursed by insurance companies for the vaccine when it hasn't been signed off on by the CDC director. So I'm hoping and praying that by September 18th or 19th, they meet, the CDC director signs off, and I would really, really hope that the CDC director says, look, it depends on who you are as to what your risk is for getting severely ill from COVID. The vaccine doesn't do a great job at preventing infection, but it's not zero. Here are the people who are highest risk. Here are the people who are lower risk. Talk to your doctor. But we're not going to restrict it for anybody. You get it if you want, and then everyone can get a shot and their insurance covers it. And that should be that. But I will probably be wrong. That probably won't happen.
Well, yeah. So one thing I want to add in, I did get the updated COVID booster. The pharmacist showed us the box. So it is out and available. Now that was in Jersey. So folks in Jersey,
is it the new formula?
Yeah, I'm going to say it wrong, but like the Conformati or something like that. So we got the
Conformati. So that's the Pfizer one.
Yes. So we got the updated Pfizer.
You think it's the updated Pfizer? I mean, that's Pfizer. It was called.
It said 25-26 on it. I took a photo. But it's not like, I live in New York, and it's not available or it historically hasn't been available in New York State, or wasn't a week ago. So maybe that's changed now. So they're out at places. I can confirm at least that, although even just the experience of trying to get that one was chaotic. And folks who maybe don't know, one risk factor, this is a little bit sort of like TMI or whatever, but one of the risk factors is being overweight, and overweight based on BMI. You might be overweight even if you don't think you are overweight. So that was that was my risk factor. Marianne Brown has a really good question that I did mean to ask that I forgot to, which is about pregnant women. Is it safe for pregnant women to take the updated booster?
So pregnancy is considered a high risk category. So I would get a COVID vaccine if you're pregnant, but of course, talk to your OBGYN, talk to your doctor. I don't want to make recommendations to individuals, but I think it was a mistake to not. And I think the CDC initially said it wasn't going to be something like it wasn't going to be available to pregnant women, which is just nuts to me, frankly.
And just to sort of like put a fine point on this, the risks to pregnant women are low to vanishing, like in terms of the baby.
Oh, of the virus
Of the vaccine.
Of the vaccine? We think the risks are very, very little. We think the risks are very, very little.
Great.
Yep.
And then in terms of the last question, in terms of the committee meeting, you referenced, I just wanted to pick up on where you had left off, which is you said I'll probably be wrong on that. If you're just doing kind of a finger to the wind check, like your best guess at the moment, what do you think is going to come out of that meeting?
Well, the fact that RFK fired Susan Monterez after a month because she pushed back against the FDA's recommendations suggests to me that the CDC director is going to be in deep doo-doo if he or she doesn't sign off on what's already been recommended, which is only to give the vaccine to high-risk individuals, that is 65 and up, and people with underlying health conditions under 65. So I think that's what will happen. That's just my guess. I don't think that's the right thing, but I think that's what will happen. Otherwise, why would you walk into the same situation if you're the CDC director? I think RFK is going to only allow that to happen, but I don't know.
And you don't think the sort of public outcry that's emerged in the past few weeks might activate a self-preservation instinct in RFK and company?
God, I mean, if I was in his head, first of all, I don't want to be in his head, but I have no idea. I would not claim to understand. I don't know him, but I ran into him on the street in Georgetown because he lives like right near here. And I was looking at him like, wow, I wonder what is going on in that guy's head. Don't know.
None of us do. The worm does.
But the fact of the matter is that pharmacies are relying on self-attestation of underlying health conditions, and the underlying health conditions that qualify you to get the COVID vaccine include sedentary lifestyle, anxiety. So I think from a practical standpoint, like anybody who wants to get a vaccine is probably going to be able to get one. Pharmacies do not have the time or bandwidth to be able to check people's records to find out, oh, does this patient have diabetes? They're only 55. I think people are going to be able to get it. I just think that the hubbub around it and the restrictiveness of it is just a distraction from the fact that people should be able to get the vaccine if they want it. And as long as they understand the risk-benefit profile for who they are and what the vaccine can and cannot do, then that's what they should get.
Indeed. Well, this will be a big week. And in the meantime, I so appreciate you spending the time. Everybody go follow Are You Okay with Dr. Lucy McBride. I look forward to talking to you when the book is out.
Great. Jesse, thank you so much for having me, and have a good rest of your day.
Thank you, you too.
Okay, bye.